Greetings from eMedi News and Heartcare Foundation of India. Welcome to our show, Chat with Dr. KK. Today we have with us Dr. S.K. Parashar, who is a past president of Cardiological Society of India. If we talk about echocardiography in India, echocardiography teaching, books, journals, abstracts, research is incomplete without the name of Dr. Parashar. First of all, let me thank you for giving us the opportunity on behalf of Cardiological Society of India to record such shows of our national and international faculty.
Thank you very much for your kind invitation.
In this chat, what we are doing is we are picking up one particular question and try to discuss it for 7 to 10 minutes, which should be very basic, of interest to a family physician and the MD physician. Today, most of the people, when they write a test, they write echo.
Yes.
But when they write blood test, they write hemoglobin, TLC, DLC, ESR, SGOT, SGPT. They don't write do blood test.
Yeah.
Okay? But when it comes to echo, they say echo. They don't write 2D, MO, they don't write systolic function, they don't write diastolic functions, they don't write anything. So it is on the mercy of the echocardiographer to do a diastolic functions or not. And you find invariably they write echo normal.
Yeah.
And when you check inside, diastolic function is not even checked. And the perception of the person is echo normal means echo normal. So my first thing is, should echocardiography also be treated like a blood test? There should be a checklist, and person should be able to mark what exactly he wants to be checked, whether you want diastolic functions or not. Because for a diastolic functions evaluation, you may require an advanced machine, an advanced technology, more time. Charges may or may not be different, which I personally feel is charges should be different when you're doing a diastolic functions. Because when I was in Nanda's lab in US, for ejection fraction, there were separate charges. So there was an echo with ejection fraction, echo without ejection fraction, and at that time in '87, $500 were charged extra for ejection fraction. So should there be an awareness amongst people that echo is not simple by writing the word echo? You must write down what do you want in an echo.
So that is the problem we face, that the patients are referred, to be very frank with you, without any clinical notes, without any X-ray, ECG. So when a patient comes to me for an echo, it is my duty to do all aspects of echo. Not that you just see some valves or something. So we have to see for systolic functions, a color flow mapping, Doppler. We automatically see for a diastolic function in some subgroup of patients also. So that it is, as you have rightly said, we do a complete echo examination, irrespective for what the patient has been referred. It is not like an indirectly for a blood test.
That as far as Dr. Parashar is concerned. But an average echocardiographer would not do it as diastolic functions. If I analyze my 100 reports of different people, 40% of them don't talk about diastolic functions. They don't talk about differentiation between pseudo-normal and normal.
Yeah.
They will just write about ejection fraction normal. Let's not talk about cardiologists. In my own hospital, when there is a case referred to me for a pre-anesthetic checkup, the only question they ask is EF kitna?
Yes.
They're not bothered about diastolic functions at all. Even if I write EF normal, diastolic, grade 2 diastolic dysfunction, they're happy. They say, oh, EF is normal. So the perception and the awareness among non-doctors about diastolic functions is absolutely zero. There was a time people used to say E upon E prime ratio is equivalent to EF. One is systolic, one is diastolic function. But nobody asked for it. Even today, after so much of awareness of diastolic functions, a non-cardiologist does not want to listen about diastolic function. Where are we lacking? Are we, the cardiologists, not being able to create an impact that diastolic functions are important for a preoperative evaluation, for management of hypertension, for management of diabetes?
See, possibly they are aware, because they should know that the incidence of a diastolic heart failure is getting more as compared to a systolic heart failure. And in a Western population, more than 50% of the patients have a pure diastolic heart failure. So it is extremely important of what is our policy. That suppose a patient of a hypertension, LVH, diabetes comes with a history of dyspnea. We do a resting echo, everything is normal, and as you rightly said, we write ejection fraction normal. The many of these echocardiographers send them back that nothing is wrong with you. But our policy is that whenever such a patient comes with a dyspnea on exertion, we always do a certain amount of exercise and repeat an echo for a diastolic dysfunction, especially when his systolic functions are normal, and we give them an exercise, and we have unmasked a number of cases of a latent diastolic heart failure and give them diagnosis. It is extremely important.
Let me concentrate on this. So you've done a basic study.
Yeah.
You've checked if systolic functions are normal. Now you're checking for a diastolic functions. You find the person has A wave more than E wave, and you say there is a relaxation abnormality, grade 1 diastolic dysfunction. Now you give him an exercise. Okay? And in an exercise, you give him treadmill
Yeah. Yes.
or just walking.
No, because
Treadmill.
now in most of the centers,
Treadmill is
the
available.
treadmill is
So when
available
you give him a
within the
treadmill
ambulance.
as per the Bruce protocol, and he becomes dyspneic. So immediately you do the echo again, and now it shows there is a rise in filling pressures,
Yes.
or it shows that grade 1 has become grade 2.
Yes.
What do you label it as?
No, we'll definitely write it because there is a worsening of the diastolic function, and normally what happens that their a resting echo usually shows some diastolic abnormality, because I have exercised patients who were controls and their resting diastolic functions were normal, and we gave them exercise like a normal individual. There is a proportionate rise in E and E prime, so there is nothing abnormal. So if so, their
abnormal.
diastolic function should be basically abnormal, whether mild or not, which most of the echocardiographers miss. And then we give them an exercise, and we have
So exercise induced worsening of diastolic function is a bad sign. It is a sign of incipient diastolic heart failure.
and it is not a good sign.
It is not a good sign. So everybody who has a dyspnea on exertion, and before subjecting them to coronary, because when you say systolic function normal, you say now I want to rule out ischemic heart disease, you go for a coronary angiography. Before that, an exercise test should be done to see whether he has an incipient or a underlying diastolic heart failure.
What I would say, we may not go for a full. So first thing is that yes, he is an hypertensive, coronary artery disease or LVH.
But in India, the commonest cause of diastolic dysfunction is obesity, even if there is no hypertension or diabetes. Obesity leads to ultimately LV enlargement.
Obesity, sleep apnea syndrome, but still we find that hypertension, LVH are still a cause, and a 2D echo plays a significant role. If I get a patient who has got a left ventricular hypertrophy, his left atrium is enlarged, that means that yes,
so my first criteria is LV hypertrophic. Second is progressive enlargement of LA. If I have comparable echoes and if I can demonstrate that LA size is decreasing, and then I go to a routine Doppler, which can pick up grade 1, and which can, with Valsalva, can pick up grade 2.
Yes.
And then I use tissue Doppler.
Okay.
Any role of specific role of strain rate, or it can be avoided only left for the specialist?
Can be avoided because what is my policy that E by E prime means that the ratio of the mitral E velocity and the tissue Doppler diastolic velocity.
If it is more than 15,
if it is less than 8:1, the patient has got no diastolic dysfunction and we can relax. If it is more than 15:1, he has got a definite diastolic dysfunction and you need not further test. But if he is in a gray zone of 10 to 13, then we do a pulmonary venous Doppler, left atrial volume index, and left atrial mass also. So that is a gray zone. So I think so, as you rightly said, that the starting point is mitral Doppler and a tissue Doppler. And those who do not have a tissue Doppler,
can you ask you a specific situation when we get patients with so-called enlarged LV?
LV.
So we have scenarios of different types. We have a scenario where we have enlarged LV with an enlarged LA, ultimately ends up into RA enlargement and RV enlargement and right heart failure. These are the people where LA enlarges, they rapidly go into from grade 1 to grade 2, grade 3, and grade 4.
Yes.
There is a subset of patients, which at least 4 patients I am following for the last 17 years. Their LV is enlarging, LA is not enlarging. RA, RV are not enlarging. They will not enlarge unless LA enlarge. And they still are the grade 1.
But what is the cause of the LV enlargement in those
cases? I'm asking. I'm asking a specific situation is that there are 4 or 5 patients which I am following. I have no explanation. I have no explanation. They have a progressive LV enlarged. When you look at the LV, you say, oh my God, this person is going to die, and the ejection fraction is low, 17, 18, 19, 20%. LV is moving like a swirling motion. Okay, but for the last 17 years we are following, their grade 1 remains grade 1. It doesn't end up into grade 2. LA is not enlarging. So unless the LA start enlarging, grade 2 will not happen.
Yeah.
And their prognosis is good. For the last 17 years, they're asymptomatic. What is, can we find out? I can't find out. For the last 17 years, I'm trying to find out a solution. I can't find out this subgroup of 4 or 5 patients. That why their LA is not enlarging, why their grade 1 is not converting into grade 2. So what is that factor which converts a grade 1 into grade 2? Do we have?
No, because for say uh, there are two basic causes for a diastolic abnormality. One is active, that is relaxation abnormality, and second is passive, that is decreased compliance or stiffness of the ventricle. So if there is the LA will enlarge and filling pressure will increase only when there is a decreased compliance or LV stiffness. So depending upon what are the cause of enlargement in your case, unless there is a difficulty in filling of the left ventricle or there is increased stiffness, possibly the LA will not undergo changes.
From clinical point of view,
but very
from
surprising.
clinical point of view, I have not taken it as these 4 cases has given me a lesson. And my lesson is, personally, when I use it, any amount of low ejection fraction, if you have grade 1 LV diastolic dysfunction, the prognosis is very good.
Yeah.
And if they are a grade 2 or grade 3, then we know that prognosis is bad. But no LV enlargement, grade 1 LV diastolic dysfunction, even if the ejection fraction is 15%, I'm not recommending CRT, I'm not recommending them ICD. My personal, I'm not talking about
Say,
literature.
but if you go by the available literature, they say anybody, but that is not applicable to our country because of
They said
economic
ejection
reasons.
fraction is less than 30%.
Yeah, you put a ICD or
ICD or a CRT. I am saying is, if it is grade 1, that's what it is. I am asking you,
Yeah.
you have a wide experience.
No, definitely.
In the conferences, try to look for such cases. Maybe we may find something able to create a literature.
Oh, yes, I agree with
Grade
you.
1, say, if a person has a grade 1 LV diastolic dysfunction, drug of choice is different in hypertension. So I don't treat any patient of hypertension. First question I ask is grade 1, grade 2, normal. If it is grade 1, I'll give them a beta blocker.
Yeah, doing so that the heart diastolic filling time
If
is.
it is a grade 2 or grade 3, I will add a diuretic. Because when we talk to people like Venkat Ram and others, they talk about first line drug, they say this, and this. But nobody talks about first line drug decided by the echocardiographic criteria. Why in GNC, echocardiography people like you, are not being invited to be a part of GNC who can modify the GNC as per the echo findings?
Because their main stress is on a systolic blood pressure. They have not, their GNC is always considered as sort of the management of a hypertension. But so that the diastolic functions come sort of a separate category also. So they are only limited to a systolic blood pressures also rather than a diastolic.
So let me come back away from
And as long as grade 1 is concerned, it is sort of a many persons above the age of 50, 55 can
they
have
say
it.
that above the age of 60, grade 1 is normal.
Yeah.
And below the age of 60, if there is a grade 1, it is a factor of that your vascular age is more than your chronological age.
Yes. Yes.
So it's a criteria of aging.
Yeah.
It's a criteria of aging. Now let me come back away from echocardiography. What are your hobbies?
My hobbies are I like reading some novels. Besides, I spend 1 hour daily reading any medical journal. That is all. But as some hobbies, I like to see some TV programs. I like to read some novels.
Have you ever written a thought of writing a medical fiction?
No.
When you're so fond of writing, you're fond of writing, you're fond of reading, and you're fond of reading novels. Why not convert the two things together and write a medical
That
novel?
requires a sort of lot of time, thoughts. Possibly, I'm not that sort of a person to
If
get
the
some nice ideas.
Prime Minister of India calls you and he says, Dr. Parashar, you have been the past president of Cardiology Society of India. I'll give you one option and give me one policy change in India and I will implement it. What will you tell him? He says, one policy change, if you give me, I will implement it right away.
I think the lifestyle modification.
Lifestyle modification.
Yes.
You'll make it mandatory in school age or you'll make it optional?
Definitely, it should be mandatory because all these problems start from a young age. So I think that will be the
You
first
have been
thing.
organizing so many conferences for the last many decades. Do you ensure that in all your conferences you provide food which is health friendly?
Sorry, no. I
No.
agree with you there, yes.
In that, at least You make sure that no trans fat is served.
Trans fat, of course, we will not like to be served, but because the problem is that most of the conference occurs in the hotels, despite whatever you tell them,
Agree,
there
agree.
will be fats and all
But
this.
then once in a while cheating is allowed.
Yeah,
So you
but no
say,
no trans fat.
but no trans fats.
No
So you are an advocate that trans fat should not be
Yes.
permitted at all.
Yes.
For reviving a person after cardiac arrest, nowadays we give them hands-only CPR. That means no mouth-to-mouth breathing is required.
Yes.
You within 10 minutes of death, earlier the better. At least for the next 10 minutes, longer the better.
Yeah.
Compress the center of the chest with a speed of 10 into 10, that is 20 per minute. Should it be taught to everybody?
It should be taught to everybody, possibly every citizen, every policeman, everywhere. It should be taught on a very mass scale. And I
On a very-
understand that you have taken up this project on a very mass scale,
Absolutely.
and I am proud of it. That I think your efforts will bring some sort of save some lives at least.
Already it has one girl, Harshita. She's a 16-year-old girl from Birla Vidya Niketan, and in the night she got a call from her uncle's house that her uncle has collapsed. So she rushed to the house and she found him with no respiration and no breathing and no pulse and no response. And she gave her successful CPR. And the person suddenly got up and they shifted him to the hospital. He was found to have an acute MI and 2 stents were put, and he was fine.
So the credit
16-year-old
goes
girl
Credit
saved the
goes
life.
to you. Yes, that is why.
Not to me.
It may not be possible to teach every citizen of the country.
I personally feel if 1% of the population is taught, whenever a person dies, 10 people gather, 1% is sufficient.
Yes.
1% means 1.3 lakhs in Delhi.
Yeah.
And that's not difficult.
And some police personnel, some other personnel. Yes, definitely.
So what Dr. Parashar says is very clearly that if he is a policymaker, he will make it mandatory to live a normal, healthy heart lifestyle. So let's thank Dr. Parashar to be with our show.
Thank you very much.
And that's all for today. We'll come back with one more topic. Till that,